Given the fact that you work very closely with healthcare technology, the latest projections are that AI will eliminate 40% of jobs in that industry. What do you think is going to reshape delivery and decision making?
Technology keeps being sold as that's the solution to the problem, and it's not. There is a resistance to adopting AI within healthcare, and the reason is a couple of things. One is
Meet Saima Anis, Managing Partner and Principal AI Architect at AugMind.ai and Chief Executive Officer at SAUK Solutions. A public health physician and AI strategist, she specializes in bridging the gap between clinical complexity and financial risk modeling to fix the broken parts of value-based care.
It's rare that people through their career think, wow, things have actually gotten worse. Where did we sort of veer to the left when we should have gone to the right?
it hasn't become better because at the outset, you're measuring yourself against a set of data that you will understand, you will absorb, you will work with. But does that data actually work to capture the clinical complexity of your physician, whose only duty is to deliver care, but now they're being overburdened by these quality measures that they have to abide by? Nobody wants to do that. I'm telling you the provider's lament. I feel like I'm always undercoding. You're telling me, well, they're not capturing everything because they're too busy doing care or for whatever other reason. It's a huge problem that's creating a huge gap.
Health plans and hospital systems need to come together to understand that we are all in this for one reason, trying to make life better for people. And how do we do that?
Very good question.
Welcome, everybody, to another podcast of When Health Freezes Over. Very excited to introduce my next guest, Dr. Saima Anis, who is a physician executive advancing value-based care, builder of data-driven health systems, AI, and predictive analytics for population health. Dr. Saima Anis, please introduce yourself to our audience and tell us who you are, what you've done, and then we'll get into all these fascinating questions we have.
Absolutely. Thank you so much for having me here, first of all, Omar. It's not my first time in front of the camera, but it's my first time in a long time. So I'm glad that I'm meeting you over camera rather than anybody else, and that we're sitting across the table from each other to advance sort of like a cause with your very quirky title. And we're going to break that stereotype or cliche with this podcast. So I'll introduce myself. I'm a public health physician. I did go to med school, and I have extensive experience in operations and strategy and tech integration in clinical informatics. And so I've been working with health systems, hospitals, public health systems, and more recently AI to advance the cause of healthcare. And the more I go into healthcare, the more I realize that clinical and the operational parts of healthcare, they're deeply enmeshed. They're kind of entwined. And so there's no one answer that will either bring those things together or kind of try to remedy or remediate the broken parts of it. So with that, I will talk about what brings you and I together today, I think, is, all the good stuff that you've been doing, and I've been doing it from the provider lens, sort of.
Okay,
So thank you very much again.
you are very welcome. Okay, so we'll start off with it's such a difficult question to answer because, you can make a whole podcast just on that question. But, what are the most critical challenges in the U.S. healthcare system that you see today? And, why you and I are talking is because I'm an actuary, you're a clinician with policy experience and healthcare technology experience. So it's rare to have folks in the same room that are from, especially when you talk about policy and actuaries, rare to be in the same room together. I've gone to plenty of conferences where you're having healthcare technology discussions, policy discussions, and I'm the only actuary in a room full of maybe 200 people. I introduce myself as an actuary, and people are surprised to see me there. And I'm surprised that why are they surprised? And then you realize, well, wait a second, I'm the only actuary in 250 people here. Why is that happening? I don't have an answer to that, but I think this is an opportunity for folks like us to sort of exchange ideas and talk a little bit and get to know each other professionally and certainly from a healthcare perspective. So, having said that, I have certain perspective on the challenges in healthcare, especially in the U.S. and overseas. I'd love to hear what do you think are policy, clinically, operationally, the challenges that the U.S. healthcare system faces, And then along with some of your experience internationally.
Sure. Yeah. So let's start with the US since, home base. We're here. I see there's a big discrepancy in the way we've been pursuing healthcare objectives at the macro level. And by that, I mean, let's look at our GDP. It's 18% for healthcare for this last couple of years. And that almost translates out to be over around 5 trillion US dollars. That's a huge amount. Compare that to the poor outcomes we've been facing with these kinds of investments in healthcare, our indices. And I'll start with a personal example of where I started in public health is instituting infant mortality reviews for the city of Philadelphia, where the rates weren't that great back then, 25 years ago, around 7.5 to 8 out of 1,000 live births. And right now, they're only, far ahead as in just 5.5 on average. And so that in itself is a big indicator of how the health of the nation is doing, right? And so where that leads us in the rest of the indices of the world is where in the 50s something compared to the rest of the countries where we stand with infant mortality. That's just one index. The others are maternal mortality. Life expectancy, we keep growing older and we keep having more geriatric, issues with care. But then we've been able to solve some. But that's another discussion that we'll touch on. However, what that's made me realize is that these couple of issues, the core ones, one being this whole discrepancy in care, it's arising from an inequity in the resources that are allocated to the population in terms of their demographics and ethnicity. So, say if I were to say 5.5 on average for, infant mortality, it translates out to maybe double that for African American population, and maybe a little less so better for the Hispanic American population. So, what does that mean? That there's a stark inequity that we're seeing and we're observing and we're not really doing anything about it, or if have we done the right things about it to make those indices change or shift in any manner. That's one. The second thing I would say is we talk about massive amounts of data all the time in healthcare, right? Well, what's happening? The data is not able to follow you through your journey in life, through your healthcare journey as a patient. If you're moving from system in, system out, public health systems to population health systems, insurers to payers, right? EMR to EMR. It's the simplest example from a provider's perspective. If the data is not following you, there's definitively going to be gap in how your provider is going to view you because that trail is not following for your historical clinical data. And so there you have it. Now, compare this to the international exposure you and I have had. We talk about the Middle Eastern countries. Over there, population health systems are, well, we won't say historically because it's a newer concept, but in the last decade or so, they've been able to adapt. And what they've done is they've followed these populations longitudinally over time in the way that they should be doing population health management. So, challenges there are these kinds of things we haven't adapted to in the US. Something to think about, some things to think about, in my opinion. So that's where we stand.
I am trying to think about, I want to jump ahead and then come back to some questions I have. Because, I mean, I've been doing this for many, many years, more years than I want to admit. And yet, it's rare that people through their career think, wow, things have actually gotten worse over 30 years than when, you started. And you think, where did we sort of veer to the left when we should have gone to the right? You think about value-based care. Now, in value-based care, CMS has a bunch of models. I don't want to get into the model details. But in Medicaid, as an example, value-based care is, you can have it on a disease category. You can have it on, for all these sort of third-party population vendors that purport savings, you can do a value-based care deal with them. So they may specialize in oncology or nephrology or whatever that they're promoting at the time, or whatever contract that they want. So then value-based care can also be with a multi-specialty clinic. And so, it can be with a hospital in general, and you can pick specific things. But in general, value-based care, if I go back, this is, nowadays we talk about value-based care as if we just discovered it. Like this is going to be the greatest thing since sliced bread. And it's been around since the 90s, late 90s. What it was and what it still is in Medicaid, and it, is basically a bunch of HEDIS measures, depending on what it is that you're contracting on. And you pick specific HEDIS measures within that sort of disease state or whatever the specialty is. And then it becomes a financial, what's called an MLR target for that particular category, right? So you put in all you bring in all the associated costs for the members that are attributed to that particular contract and say, okay, now you're responsible for all these costs. And the deal is going to be an MLR deal. And so let's say the MLR is 88, or historically MLR was, what you want is, at least from the contractor side, you want an MLR that's like 93, 94, some sort of runaway train that you're going to bring down and then they're going to share in the savings. But let's say for argument's sake, it's 92, 93. And the contract sort of machinations are you pick the base data, you figure out what the mix of the members is, and then you figure out what the trend is going to be, and you turn into the contract year and you all agree to all the terms and you say, okay, we think it's going to be 93% even in the future, and we're going to bring it down to 88. And so then you have what's called risk corridors. So the 93 says, okay, at 93, at 92, you're going to share this much. At 91, you're going to share this much. At 90, you're going to share this much. But at 94, you're going to lose this much. At 95, you're going to lose. So there's a deal around that particular target that you've agreed to, along with a couple of percentage points kept away for all these HEDIS measures. So sounds great, like, okay, we're going to, you're responsible. You're going to get share in a significant windfall if we're able to manage this population that has theoretically been unmanaged. Now it's difficult to find unmanaged people at this point in 2026. But let's say for argument's sake, it's there. So the issue then is, okay, this is 2026, but when this happened, back in the 2000s, whatever, it was supposed to be along with things like consumer directed health plans. I'm not sure if you know about that. That was high deductible health plans. The idea there being that
Commercial help.
commercial health plans, right? The idea there being the higher the deductible, you're going to be more aware of yours. You're basically getting sort of stung by a high dollar, so you're going to be careful. I think it's a terrible idea. But anyway, that was the idea. So, you had this sort of version to manage trends for employers, maybe self-insured employers. You had value-based care deals to sort of somehow manage trend. And now here we are in 2026, where my premium just went up 25%, right? So help the audience understand at a cursory level, because you and I need to probably have another podcast on just value-based care deals. That could just be a podcast unto itself, maybe two. Give a cursory sort of your opinion on how it's sort of, what's happened in your opinion on value-based care and how it's transpired and where did it get lost?
Very good question. And the context that you set up for it is also exceedingly important. However, let's clarify a few things for our audience. One, when you're structuring deals, what MLR stands for as a percentage?
MLR stands for what's defined as medical loss ratio, or MCR, Medicare care ratio, which is traditionally claims divided by premium. Now, there are some nuances around that definition, but historically and traditionally, it was always claims divided by premium. So how much money are you spending per dollar premium on actually delivering care?
Now, to set the context, contextualize what he just said, let's tell our audiences that we're setting this up in terms of contracts that we're driving up to actually measure the risk that our populations will pose on a healthcare system, which is then mediated by people like Omar, who works for the health payer side and the insurance side to lay out this risk for the populations and then sort of translate those measures that he talked about, the HEDIS measures, which are actually national quality measures for payers and insurers that provider side has to follow in terms of transmitting data over. Now, this is not the only thing. And his final question was, well, why hasn't it changed? Why hasn't the situation become better, for all of you to understand? It hasn't become better because at the outset, you're measuring yourself against a set of data that you will understand, you will absorb, you will work with. But does that data actually work to capture the clinical complexity of your physician? Who's working with those complex clinical environments in that complex clinical population with their patients, whose only role or only duty is to deliver care, but now they're being sort of overburdened by these quality measures that they have to abide by. So it's like a huge administrative burden on these providers. And I'm going to advocate for them because had I been doing clinical care, I would have been in the same boat. And I see my friends and colleagues who I went to med school with and otherwise struggling with this time and time again, over and over again. Nobody likes that administrative load. Add to that the additional burden of the MIPS, of the STARS. These are short forms for provider and measurement quality measures that they have to abide by. Nobody wants to do that. But if people like you and I set out to sit in a room before even the whole care delivery model was designed, Umar, wouldn't that make such a big difference before we even gave out a contract to someone to sign? That I could think in terms of what the provider is ailing the provider, and you could think in terms of what would be actually necessary to capture in terms of data and within claims data which things are missing and how we could make this into a wholesome offering to those contracts, right? We've not done that. This is probably the first time in my lifetime that I'm sitting across from an actuary. So I think we might be making history here, you know? But the other thing is, are we aligned? We've never been aligned as two different
Well, we didn't know each other.
subdomains, as
Right,
subdomains
right.
contextually. Doesn't matter the humans involved, but it is a humanizing thought, right? It occurs to me that we're now fortunately here in one room discussing this. I've never had the opportunity to discuss this before and to hear it from your side also. The other very big problem is when you're going in primary care, the problem is only as simple as, so let's go back to value based care. We talk about this, term. What does it mean? It's incentivizing the performance and the payback to the provider by the kind of work that they're delivering or the care that they're delivering. How does it get incentivized? Either by dollars being given back to them, or them doing extra preventive medicine work for your patients, or reducing admissions to the hospital, cutting test costs, all that category that Omar said might need another podcast or two. That is what value-based care entails. Let's look at the older model of value-based care. What did it do? It didn't necessarily punish those people that didn't produce the outcome, but it gave bonuses to the ones that did. That didn't help change behaviors or incentives, did it?
No.
Right? So how do you expect that from time immemorial, when this was instituted back in the 90s, 80s, whenever in the US, that if there wasn't an incentive tied to it, that behaviors will change and that a whole lot of system change and then trickle down effect in terms of better patient outcomes and less costs might come about? It won't. So the better model, and well, there are ideals also set in society by mixing models, but at the current time, the better model seems to be like when you assign full risk to the provider, and then you say, okay, well, you're in this. Only going to give you this much for producing the outcome. It doesn't mean you have to do more preventive care. It could also mean that you do less work and you keep the patient out of the hospital for whatever you do, right? So the provider has less burden for care, and the provider is producing the outcome. And if you don't perform on these measures, then you're not going to get, you're going to incur a higher financial cost to your institution or your personal practice or whatever under that. That's the full capitation, the full risk model. That seems to work. This, however, is very applicable in not just primary care, but, in specialty care. You've heard of Chen Med and
Sure.
Oak Street?
Yeah, yeah.
What do you know about them? Let's talk about those. Those are excellent examples.
Yeah, I don't follow them, but I mean, I know about Chen Med, primary care practice out of Miami, and it has obviously been very successful in the primary care model.
Yeah.
But if you know more about it, please,
I
share
mean,
with the
you've
audience.
seen those signboards out here in
Oh yeah,
Philadelphia.
sure.
The year or two after, couple of years after it started in Florida, you had the Oak Street, Chen Med, you had them out here. And you were wondering, who are these people? They're the people who are mixing the two models together in terms of primary care and specialized preventive care. I'll touch on specialist care also.
Okay, so
Yeah.
before you do that, let
Yeah.
me just talk a little bit about full capitation, right? So full capitation is not an innovation. Full capitation has been around since early 90s, or probably that's sort of the HMO model that came out in the 80s, right? So hospitals have been willing to take on risk. Well, actually, back then it was, and I'm seriously dating myself here, but back then it was like physician specialty groups that would take on capitation, right? We would do capitations for PCP groups and specialty groups. Hospitals came into play later on. The problem with full capitation is twofold. One, if you do it with a physician group, they don't bother submitting the details of the claims anymore because they're just getting a capitation, right? So what happens on the end of the provider of the payer is they don't have fully populated diagnosis codes, so it mucks up the risk adjustment, right? So you don't really have a sense of how, what is the accurate risk, not that risk adjustment is the end all be all. I mean, I don't want to use statistical terms, but like the R squared, which is the predictive value of these things, basically says, okay, it's only like 28% or thereabouts. That's the best. So it really has a predictive value of 28%. So it's not like, having fully robust risk adjustment factors is going to give you 100% predictability. So it's 28% at best. And so if you don't even populate that, the ability for a health insurance plan to get accurate revenue for its members based on risk adjustment gets seriously degraded. So that's one issue with capitation. So then what happens is with health plans, they start to spend money to incent the physicians to fill in the diagnosis codes. So that's one issue.
You're
So
opening a Pandora's box here. You
I
understand
am, but
that.
I'm just telling you what it is from the health plan perspective.
Right.
And so, again, I'm not taking sides. I'm just telling you the reality of what it is from an
Absolutely.
analytical perspective.
Yeah. You're laying the facts as it works today.
Second, the issue with full capitation is what that's just done is it's transferred the risk from the health plan, because there's no longer shared risk, it's a full capitation risk. So now health plan, a hospital XYZ has the full risk for that capitation, or the specialty clinic. Let's make it a specialty clinic, orthopedic clinic, right? An orthopedic clinic has X number of physicians in there, and they decide to take on a full capitation. Why they did that, I'm not sure who guided them, because now suddenly they're now an insurance entity. Do you have the ability to understand what you have the capitation coming in on a monthly basis? Great. But when the renewal comes in, do you have any sense of what the renewal is going to look like? Because you don't know what the mix of the membership is looking like on an underlying basis. Do you understand? So what happens is that the predictability of the cash flows becomes a real problem. This is what happens with when hospitals decide to take on full risk, and some of these, like these population health vendors start to take on full risk. They don't know what the predictability is. And by the way, the settlements, when a health plan says, we're going to settle up with you at the end of the second year because we need 6 months of run out. So you will keep getting that capitation. That settlement might be a serious negative by the time they come up. And so you don't have a sense of what to accrue for because you're not an insurance entity. You don't have the organization structure, risk-taking capacity, the financial structure. You're a healthcare organization that's delivering healthcare. You're not expected to understand that. So I think that, when I think about full risk and all those sorts of things, those came in waves. It was a very in thing in the 90s, poof, vanished off because PHOs came in. PHOs were basically health insurance, health plans set up by hospital systems because they thought, hey, what better way to get members? Just let's start our own health insurance company. Well, that went sideways as well. So I think there are some, and I think this is where I'm trying to suggest where folks like you and I, so what I mean by that is health plans and hospital systems need to come together to understand that we are all in this for one reason, trying to make life better for people. And how do we do that?
And you, on the other hand, are there to make life better by thinking about risk adjustment, which is what you started your conversation with at this instance. And I want to tell the audience that this risk adjustment stuff is based on murky waters. And the murky waters have to do with this huge gap in the ICD coding and what the actual clinical complexity is of the case in terms of high-risk patients. Say if you want to take orthopedics as an example, you were to take maybe oncology as an example. You and I have friends who are oncologists, right? And we see that they run on a scale of severe cases and then different pathways to journey to care, to treatment, and then to recovery, to prognosis, all of that, right? That complexity is not adequately captured in the ICD coding. So primary care definitively misses that. They're undercoded. And what that does is then also the benchmarks that you set the 1 year, right? Well, they've done their job. They're okay. There's lower benchmarks. Next year, they're not going to get the shared savings. That's one spectrum. That's one end of it. The other end of it is these high-risk scenarios in oncology and orthopedics and whatever have you, complex care, chronic diseases, they run a full gamut, which is not captured. So what you're doing is you're saying that the more specialized complex care problems require specialized coding for these high risk, but you're not providing that. There's no one coding mechanism to capture that. And that's why that's being missed. And that's why the reimbursements that you say someone who set out to say, I'm going to do full capitation, I'm going to receive it, isn't able to receive it. So it's an inherent flaw in the design of the system. And it's an inherent flaw also then in the delivery of that workflow in the clinical realm. The clinical people aren't able to tell you what they've captured adequately. So then obviously the calculations aren't going to match, right? So then they're going to be under a threat of like losing revenue. Those kinds of things, if we anticipate, like you and I are talking about, I'm telling you the providers lament. I feel like I'm always undercoding, right? You're telling me, well, they're not capturing everything because they're too busy doing care or for whatever other reason. It's a huge problem that's creating a huge gap. It comes down to a data gap also. It comes down to an understanding gap, and it comes down to how do you simplify these models that you institute. So in primary care, undercoding is one issue. Another issue with value-based care and a terminology that goes hand in hand is social determinants of health. That's not being captured. So the claims data that you're receiving and is completely missing that point from, say, primary care's perspective, then what's happening? You're saying that the physician is inefficient, the outcome of the primary care patient are poor because he's coming back, but they're not necessarily for the care that the physician gave, but for the things that he's not getting to him in time in his environment, right? The social risk factors. So stratifying populations by those risk factors then becomes really important, and I don't think we've been able to, from your end, adequately capture that. There's also technological and platform and analytics and data caveats within a healthcare system that sometimes prevent providers from capturing that information. We can go into that also, but these are some of the things that happen.
So let's talk a little bit about, so social determinants of health. It's becoming very clear to me that that is a very consistent conversation. There's a din around that constantly. It's like a buzz in your ear. I hear it everywhere. And it's fascinating to me that as an actuary and a healthcare data scientist, etc., when there are programs, but when it comes to pricing a product, the state for Medicaid, I haven't seen it. I mean, I've seen pricing for many years. I've been in Medicaid for over a decade. And you look at the state pricing, there's no layering in of SDOH, meaning they don't look at SDOH data and say, you know what, we're going to add in a couple of dollars on a per member per month basis for food security, insecurities, housing, access to transportation, education, and language barriers. And what's interesting about that is that depending on what studies you look at, I was shocked by some of the number of studies that were coming out. Between 50 and 80% of ultimately claims are determined by, and it's not surprising, it's just common sense. If tomorrow you start eating hamburgers all day and having chips and Coke, you'll see what your blood profile looks like in about a month. Materially different than what it is today. So it's not surprising that some studies suggest that 80% of claims manifestation is due to the poor choices or the lack of choices that you had in your life growing up or whenever, right? So, I think when we talk about from an actuarial perspective, actuaries don't spend hardly any time. I mean, I'll just talk for myself. I've never spent any time on SDOH analytics, right? Because it never was front and center for a health insurance company.
Was it even captured in the claims data that was given
It
to
was
you?
never captured in the claims data. It was captured in provider data that the providers had access to within our organization when I used to work for the industry. And that to me was fascinating when I discovered it one year. I was like, well, what is all this data? And how come we never even look at this or talk about it? And so I think that, so I mean, do you have some thoughts on that? I mean, I can go on and on about
No,
SDOH.
no, I hear you. And so SDOH simply is what are your lifestyle and your social risk factors around you that will impact your health and your healthcare outcomes, right? And the way you function in society. And it's a really important and life-changing moment for providers to understand that specifically in primary care, because primary care, the patients look healthier than they are because the SDH is not captured. Like, do they have food insecurity? Do they have housing problems? Do they have access to healthcare, getting in a car or motor vehicle or transport to get to the hospital or their doctor? Do they have a job? Are they eating the right fruits and vegetable servings every day? Are their children being taken? Everything and anything that goes around that impacts mental health, psychosocial health care. Do they have friends? Do they have support systems? So all these things need to be accounted for. That's social determinants of health risk factors. Prior to this conversation, I don't think, and in the times that you were not seeing the data available, nobody was stratifying populations to account for that risk, right?
No,
Like,
because
and now there's been a drive in the last decade. And when you talked about state, I was thinking about to my time with the health department, where there was a consortium a local consortium in the greater Philadelphia area that came together to put all the hospitals, at least the birthing hospitals, on one platform. That was one of the vendors in running that was actually endorsed by the state, and the state subsidized the cost of acquiring that vendor to these hospitals. And I was the first one to go and tell the health system I was advocating for, please go ahead and get it, integrate this with the EHR so that you are able to capture those indices that you're missing to send back for capturing your Medicare and Medicaid, your payouts. And so what happens, again, technology, right? It's a great enabler. It can't solve all your problems. So it started the one-way street to capture that so the physician could make a referral out, right? But it never closed the loop at that time to bring the data back in to what happened to the patient after that referral was made. Great platforms. They still exist to that day. And I'm hoping that is happening right now. And if that is happening right now and it comes down to bringing that data back, that would have a big impact on keeping our patients, the high complexity patients in primary care, high complexity without making the provider look dumb, basically, right? So that's one way to think about it.
So why don't we talk about healthcare technology and what your perspective is on, everyone talks about healthcare technology or AI. I mean, that word is being bandied around. And so I've worked at and with insurance entities. The latest projections are that AI will eliminate 40% of jobs in that industry. I'm not sure I doubt that because given the level of bureaucracy that exists in those organizations. But what are your thoughts on, given the fact that you work very closely with healthcare technology, how is that going to, what do you think is going to sort of reshape delivery and decision making?
Yeah, but specifically the value-based care argument and the perspective, technology keeps being sold as, that's the
End
solution
all
to
be
the
all,
problem.
right?
And it's not.
Yeah, of course
It's
not.
not, because the problem, we over investing in technology, and we're under investing in something else. We're really under investing in the people that work with the technology to bring them up to par with that technology. That's one thing. And we're also under investing in changing the clinical workflows designs that people like you and I should sit down, figure it out, and then extend the contracts. The workflow design and the clinical care delivery plans needs to happen before a contract is extended. Technology cannot do that. What technology can do and has been doing in the last decade very efficiently is it's telling me in a complex patient, like a diabetic patient who is now going into nephropathy or his kidneys are failing, right? I can predict that high risk disease outcome 10 years earlier so that I can prevent his visit to the emergency department. Technology is able to do that with predictive analytics. That's where the analytics platforms and data analytics comes in, which you're familiar with. And then AI can also tell you which populations could be at high risk given their certain ethnicity or a demographic. So AI is very good at catching that. It can do natural language process semantic analysis of just like qualitative data, right? It doesn't have to be numbers and figures, and can come up with parse out information that occurs, patterns that occur over and over again. AI is generative AI, at least, can do that. There is a resistance to adopting AI within healthcare, like you said. And the reason is because a couple of things. One is confidentiality, maintaining HIPAA requirements to the utmost, and compliance and regulatory requirements at the same time. And then bringing in something like technology to say, okay, well, we're going to change the way physicians will see a patient. That kind of behavior change, again, is an incentive-based change. So what we're overlooking, technology is great for implementing data in platforms. We can have all kinds of analytics. I can have a fully functional EMR that is as robust as causing millions of dollars in revenue and do foundational updates as a clinical informaticist and all that. But what we're missing here, with technology being the greatest enabler, I'm a huge advocate, is that it's not setting out those care management pathways correctly for us. It's not engaging the physicians to change their behaviors, and therefore it's not engaging the patients to change their behaviors adequately. So, and if we were to go at it from a lens of change management, then technology would be the best thing that ever happened in healthcare to do the kinds of work, that we're trying to do. Save money, produce the best outcomes, maximize on our resource efficiencies, do away with the inefficiencies, do away with the gaps, and no duplication of effort, But that's not been happening. And that's where, and maybe technology is the answer, but have we tested it that way?
So, going back to sort of your background experience, we've talked about full capitation, we've talked about VVC. If we generalize it for a health system perspective, what do you think these health systems need to be doing? You want to insert VBC in there. What would you advise a health system entering into a VBC contract or a full risk capitation contract? What's the clinical things that they should be doing? And then I think, what are the technological things that they should be considering, not from a health plan perspective, but from a health operating system perspective? The other end of the spectrum.
Yeah. So I would say if you're going in, even thinking about a risk contract, before you sign anything, study your patient population really well. Know their SDOH risk burden. Know what cost drivers there are that exist in that population. Know exactly what kind of cohort you're dealing with and their clinical reality on the ground. Don't make projections based on what you think you know. Actually go and study that. If we're able to study that and then devise a contract in a way that we're covering these gaps, I think health systems will end up saving a lot more money, and so will the insurers. And how technology can help there is it can help go in and help you with your risk modeling, predictive risk modeling for those situations. So that's what I can think of.
Okay. So now this goes into the other question, is if you want to read, and we're thinking out of the box here. You had your, you know, wish of redesigning a healthcare system. Where would you start? I mean, given where we are today.
Oh gosh, I have a huge wish list, but I don't want to go through all my wish list because, we'll be here till tomorrow. But if you told me, give me 3 or 4 things I'd want to change, right? So people like you and I should come to the table early. First off, there's never been a meeting of minds in terms of people who are doing the math and the cost structures and the financial trends and the cost trends, and people like me who are talking about, fully reflecting and bringing to the table the grievances from the clinical providers end. So, because even though I may not see patients, I know exactly what ails the system because I get that from the physicians that I work with. So, on the other side, the clinical physician providers should understand their patient's complexity and their disease progression, and we're not always thinking in terms of the same risk pools, right? So we kind of have to align there before we do anything else. Next, I touched upon this in the beginning a little bit. Data is siloed, and I talked about it in terms of the EMR system. But when I say data is siloed, it's also siloed in terms of its consumption for you, because systems aren't interoperable. Interoperability is an IT construct, and what that means is that if we aren't able to move things, if aren't able to adapt those things from one system to a system to another and convey data across platforms and make it standardized, that whole process standardized, we are unable to care coordinate in the end, and therefore we'll be left behind. So data is foremost, and
Data is
it's
king,
the
right?
truth.
Right.
It's the source of truth, right? It's what's actually happening. It's a factual representation of what we're seeing in society, in populations, and in the patients who are sick in all these realms, right? Those are our perspectives. The second thing is, you're saying it's a financial risk. I'm saying it's a biological and disease risk, right? We need to come to one definition of risk. Can we do that? Are we ready to even approach that subject? That needs to happen foremost. And these they seem like very nuanced, like highfalutin ideas and thoughts, but we really haven't come to the table with the same understanding. You come with HEDIS measures, I come with MIPS measures, right? We need to bring those together. Things of that. And then we co-design the value-based care model that we think we want to. So that care delivery that's going to happen, right? Last but not the least, and I'll say this over and over again, and take this as a power example of what could change the entire universe of the problems we're facing within healthcare delivery today, is focus on the highest risk patients. You've heard of those examples where they're talking about the kidney care patients, right?
Yep. Nephrology. Yep.
Dialysis.
Dialysis. Right.
What can you change there? They're the highest risk, highest cost.
Yeah.
Right? So with quality measures, you know exactly what we're talking about there. Focus on that. If we can align on these few things, I think we have a very good start and a more optimistic outlook and less skepticism about the whole thing.
Okay. So this takes me to my next question. Usually I ask all our guests, how can actuaries and the guests' sort of background expertise work together? But I think the other way of looking at this is, where do you see the actuarial and clinical divide? So, I'm trying to be more positive about it, but how the actuaries and clinicians can work together. But what needs to sort of, I guess we need to start off with is, where do you see that divide, and how, where do clinicians and actuaries just don't understand each other? And I mean, you've touched on it, certainly, from a risk perspective and a care perspective and a financial perspective. But, you being on the other end of this and not having spent any time with actuaries, you and I have gotten to know each other professionally and personally. I'd like to get your perspective on where you think the divide is, where the misunderstandings are. You don't have to list all of them, but maybe a top three, and see how we can start to close those gaps. Because I think I go back to the fact that I believe health plans, and I've talked about this repeatedly, health plans, in my opinion, are fast becoming just brokers earning a commission on shoveling dollars here and there, rather than value added services in the supply chain of healthcare. So this gap between actuaries and clinicians could be another venue for health plans to close that gap and close that understanding.
You're modeling the risk,
Yeah.
financial risk. I'm advocating for managing their care better. That's the biggest difference. We're looking at two versions of the same patient. You're looking at it from a population standpoint, where more than one patient is involved, and how you can benefit the entire gamut. And I have one patient at a time, and I'm thinking, how can I take care of this particular person in time and get them the best care possible with the best utilization of any model that exists out there? If we can see eye to eye, if we can merge those two worlds, I think we have our answer. That's where the divide is currently, right? And that's why we're not aligned on incentivization. So in healthcare, one of the very basic things that we're taught as public and population health proponents is it's the way you change your behavior, right? It's like a spiral. You come to it, the theory of behavior change actually says that you can come to a point in that spiral where you get stuck at a point, and I think that's where we're at. We're stuck at a point where we are not traveling that path together, but in two parallel ways. The way to bring it together is to start having combined definitions. One cause, which is, right, we're going to handle the care better. If we don't penalize, will that change behaviors? If we don't penalize the physician, is that going to change behavior? If give them full burden of accruing the cost, is that going to change behavior? Is there an in between? That in between, that thin, fine line is what we have to find.
So let me spin this question this way. If you had a department of actuaries that can analytics, with data scientists, how would you leverage that function in support of hospital systems, like our local hospitals here, Jefferson and UPenn, et cetera? How would you leverage the actuaries to support you and give you greater insight in, for example, we're getting into full capitation contracts or VBC contracts, or, the current financing mechanism is contract with the health plan. That's your revenue source. How would you use actuaries to better support you if you had your own hospital system?
It's not that the value-based care models will change any system or a health system. It's what the actuaries will dole out as a risk model that will change the healthcare behaviors in a health system, for the provider, for the patient, for even the administrative staff, right? So if you are able to prove that in graphical form or a tabular output, and you're taking care of the analytics of it, if that is supported by the clinical evidence, right? From our end, from the provider's end, that's what needs to happen. If you were on board, which pretty sure all the health systems require them to have, and now a lot of health systems are also becoming provider pair health systems, so they're integrated delivery healthcare networks. So they're doing the same thing. What they're trying to achieve is this whole goal of bringing the two together on one page. And so that's where your value would lie, and that's the value of us, people like us working together, would also lie.
Okay, Dr. Saima Anis, this was very, very helpful. I really enjoyed it. I think there's a lot to unpack there. It's difficult to sort of jam it all up in 1 hour, but I think we're going to have a few more discussions. I see more discussions from the hospital provider system perspective. I see more discussions on the value-based perspective. I see more discussions on just us agreeing to clinical versus financial terms. I think there's such a, I don't think the miscommunication, but that's how the industry's worked out, where we're all in our own corners, and it's sort of a zero-sum game for the industry. Either the hospital gets the money, physicians get the money, or the health plan gets the money. I think we've lost focus on what it is that we're doing in this industry in the first place. So I think there's a lot to unpack there. I really appreciate your time. I really enjoyed it.
Thank you for having me.
Yes, you're very welcome. Thank you, everybody, for joining us on this podcast. We will see you soon. Thank you.